have a specialist MSK physio, senior member of the team, strength and conditioning lead at LDN Physio. But we're talking to you today because actually it's the practitioner becomes the patient. So normally you're here and lower limb injuries is your thing. People with knee injuries, ankle injuries, hip injuries, they come to see you. How many ACL injuries do you think you've seen in your life?
Probably close to 100, I would say, across 5-6 years. Yeah.
And you unfortunately suffered an ACL injury yourself.
Yeah.
And this is what we want to talk about. I think there's a lot to cover. So maybe let's take it right back to the beginning. What actually happened?
So, to actually drag it right back, this is a second injury.
Oh, okay.
On the same leg. So 6 years ago, I had a partial tear while playing football of the left ACL and medial meniscus, so the inside meniscus. Back then, I decided not to do surgery. Rehabbed it conservatively, and for 6 years I was completely fine, skiing, playing football, everything.
No issues?
No issues at all, not at all. In April this year, I again was playing football and ruptured the left ACL again. This time was a full rupture, and the lateral meniscus, so the outside meniscus. So now the situation was both meniscus was torn and a full ACL rupture.
What was happening in the game? Was it during playing?
It was during play. It was the very last ball of the game, as it usually is. And it was a movement that everybody who plays football will do a million times. I got the ball, knocked it towards the left, and the opponent stuck his leg in front of me. I jumped over it to avoid contact, and as I landed on my left leg, the knee just gave away. Heard the pop, heard the crack, instantly went down, 10-15 seconds of really, really high pain. And then it was kind of usually, as usual, it kind of gets a little bit better. Most of the time you're able to stand. I was able to stand and kind of hobble off. I think I wanted to convince myself that it wasn't the ACL.
Yeah, that's what I'm thinking. When you're there,
yeah,
what was the first thought in your mind?
I knew it was something serious because obviously the crack, the pop, and the pain was just too much.
Yeah.
But I wanted to convince myself that it was the lateral collateral ligament and meniscus. I didn't think it was the meniscus. I got that one right. Just because I actually felt the tibia shift laterally. So I was like, oh, there's a chance that hopefully it's just the collateral ligament rather than the ACL. In hindsight, it was a silly hope, to be honest. Not because it had to be the ACL, but because you just don't know.
How does it go from there to the actual diagnosis?
So obviously straight away I knew I had to sort out the MRI. So that evening I messaged you guys, be like, I did my knee in, I can't come into work tomorrow. I straight away kind of got on the phone with the insurance, and we have obviously a great network of knee surgeons that we can reach out to. And I went to see one of them. Got the MRI. First, I got the MRI sorted through the insurance, and then I went with the MRI on hand. I went to see the surgeon.
Amazing.
And then obviously he confirmed the diagnosis.
So the question that we get asked a lot when people come in and they've had an injury is, do I have surgery or don't I?
Yeah.
It's such a common thing, and especially when they read online or their doctors, they get told one thing or the other. And sometimes, probably a lot of time now, we've got a lot of surgeons who are, quite balanced with their arguments, and especially if they're in a position where they have both choices. Yeah. So then they ask us, right? So what do you think? So now you're on the other side.
Yeah, and I've done both.
You've done both, yeah. So what was your thought process, and how did you come up with the decision?
So from the first injury, my thought process was, if I get a second injury, I'm going to get the operation done.
Fine.
Okay, so that was, as soon as I heard the second diagnosis, that was my thought process. But then obviously I thought about it and discussed the pros and cons further with us, with the team, and with the surgeon. My final decision was, of course, surgery, with having 3 structures inside the knee that were compromised. I do think that the risk of surgery was lower than the risk of carrying on with 3 structures that were compromised, both from a long-term perspective of possible arthritis and from a short to medium-term perspective of getting back into sports and then having a much bigger injury in the meniscus, for example, or any other ligament in the knee, which would have made things a lot more complicated. So I was always kind of 70 to 90% stuck on surgery. I did take my time to think about it, but yeah, surgery was the correct choice. But for example, Nico and I had another physio, had a discussion with the patient the other day, who has an isolated ACL tear, and one of the surgeons that we collaborate with was like, actually, I don't think you need surgery. And then he had a bit of a second opinion, and he's still deciding. But yeah, there's very much scope for conservative treatment.
Because I think that obviously a lot of the answer is obviously it depends, and I think you alluded to that. Sometimes maybe it's one structure isolated or multiple. Is there any other things that can kind of sway it one way or the other?
Yeah, 100%. Say you've got a date by which you have to do a race or you have to do a competition or something like that, right? If you can't afford to miss that, then you can't afford to wait and try conservative for it to fail, then have surgery, then have to go the 9 to 12 months post surgery. And that's a lot more important for elite athletes or people that have that deadline. Us as amateur athletes and kind of normal people, we rarely have things that we can't wait for.
Does age play a part generally as well?
Not really. No, I don't think it does. I wouldn't suggest that someone gets surgery because they're older or younger. I think level of playing, level of competition will have a much bigger impact.
For those that come in who are maybe late 30s or 40s and they say, I'm old, and my football days are over, it's not necessarily the old, it's just that, their level may have just dropped because naturally they might not be playing at as high level as opposed to thinking it's all about their
And if they want, it depends what you want to go back to. Really, that's what's your goal. If your goal is, okay, you're 40, football days are over, you have this ACL, but really you want to go hiking and you're not really doing anything massively dynamic or pivoting in nature, then you probably don't need a surgery unless there's ligaments, meniscus, maybe 3-4 structures that are compromised, like in my case, and it's probably worth preserving the knee, so having the surgery.
So surgery's booked.
Yeah.
Now I think I thought
there was a little bit of there was a little bit of timeline issues in between, but yes, let's say we got to that point.
We got that booked pre-op.
Yeah.
So kind of prehab.
Yeah.
It's a thing that we talk a lot in the physio industry. Some people have never heard of it.
Yeah.
Some people don't go through it.
Yeah.
So what is it, and then what did yours look like?
Yeah. So I can't emphasize more how important the whole prehab done properly is. What is prehab? Prehab is rehab before surgery. And at the end of the day, it's exactly the same things that you would do post-surgery, which seems counterintuitive. Why am I doing all of this work if then I'm going to have surgery and I'm going back to square one? The point of prehab is to get you to surgery with full strength in the leg muscles and full range of motion in the knee, to the point where you get to the surgery day and you're like, I might not even need this actually. Obviously the reality is a little bit different because of the things that we've just discussed, but it's super important because the analogy I always give patients is, when you have surgery, you're going to regress. You're going to lose strength, you're going to lose range of motion. But if you go in here, you're going to regress to here. But if you go in here, you're going to regress to here.
Exactly, yeah.
So then that's the mountain that you're going to climb instead of this.
There's always going to be a dip, but you want to start off
Yeah,
at
you
a
want
higher
to start
point,
as high as you can, so that the dip brings you down to the best place possible. Mine was 6 months worth of prehab, definitely towards the longer side.
Yeah. If someone did have it, let's say surgery was booked in a month, out of their control, or they may be really anxious and they just wanted it done.
Yeah.
Could they still prehab in that time?
They could definitely still prehab in that time.
Not ideal, but...
It's not ideal, but it can be done, and you will still get good gains, and at least you will get to the surgery with most of the range of motion and a calm knee, and probably not the strength that you need, but a good enough knee.
So no excuse to not do
No excuse to not do at least 2-3 weeks, because be it NHS or private, the waiting times to see the surgeon, have the MRI, see the surgeon, book the surgery, is going to be at least a month at the end of the day, unless you're super lucky.
Yeah. And is there a difference between kind of someone who is, let's say, very active, very sporty, and then someone who had an ACL injury, like
maybe
a freak
just like
accident.
an accident,
accident. Then they're not active. They've never been to a gym. You know, is the prehab different in those people?
The prehab is not different, but you're going to start at a different level.
Yeah.
Because one, the active person will have a baseline strength, will have a baseline level of athleticism, and will or might already be acquainted with some of the exercises that we're going to go do. So I don't need to teach you. You can carry on and already start at least a moderate level. While the sedentary person will have to learn the movements, will have to learn a lot about their body, how they move, and to be able to feel their body, if it's doing the right thing or not. And then you can start teaching them the movement, and then they can start loading that movement to actually build the strength. So it's gonna be different in timelines. It's not gonna be different in approach. It's going to be different in level, but the aim is always the same. Calm knee, full range of motion, good strength.
So you had surgery. Have you had surgery before, or was it your first time in hospital?
No. I had surgery before, but nothing this major.
Yeah.
To be fair, it's all quite small stuff, luckily.
How did you feel?
Calm enough, because I chose a surgeon. I know. I see it every day.
Yeah.
I know what's going on. I know exactly what they're going to do. I know it's a routine surgery. It's never an easy surgery, that just doesn't exist. So, no, I was quite calm.
Okay.
There was a small percentage of I'm still going under general anesthesia and I'm still having surgery, which carries risk. It carries risk of infection, it carries risk of mortality at the end of the day. Unfortunately, very small, but it does.
And you have to sign a paper
you got to
saying
sign
you're happy with that.
the disclosure, absolutely. And you go in, and you do it. By 6 months, by all the prehab that I've done, I was so ready to have it done and start the rehab that overcame the kind of the nerves.
And what's that like the first 72 hours like? You know, post you just had surgery, you've woken up, and then the first few days. What is that like?
So I woke up in recovery, and I remember the surgeon coming in when I was still a bit out of it from the anesthesia, and I can't remember seeing him because I was probably all just out of it. But I remember his voice being like, "It all went well, all good." My first thought was, "Do I have any range of motion or loading restrictions?" That was the first.
Tell me.
Tell me everything.
Yeah.
Even though I could not actually string a sentence together. But he told me this, and then within like an hour or so, I kind of came to my senses, and this is where the physio in me is useful, because straight away I was like, all right, can I activate my quad? And I started straight away doing quad squeezes pretty much like 2 hours post surgery. A little bit of range of motion work, and then kind of looking at it and assessing does everything look in place and okay, right? So then everything looked fine, and I calmed down, and I was just like, okay, it's done, that's it. Then they take X-rays, right, post-surgery, because they need to see if the screws and everything are in place, and if something goes wrong after, they need to know that when it was right post-surgery was fine. I went home the same day. I didn't sleep there. That is because I had it early-ish in the morning. There was enough time for the analgesia and the anesthesia to wear off.
Were you happy with that? Because some people
I was happy with that.
Like, I might, I'm feeling a bit of protection
Of course.
with people there.
Yeah,
but,
yeah. And my family was like that when I told them that I was going to go home. Oh, but is it okay? Is it normal? Is it... and actually, I want to sleep in my own bed.
Yeah.
I don't want to sleep in the hospital. I don't want to wake up in the hospital. I want to wake up at home. But you do need the correct amount of time to be able to be under observation and to make sure that everything is okay. And also, we collaborate with the surgeon. I know him. He knew that I would be vigilant for all the things that you need to look out for post-surgery, so he's probably a bit more comfortable sending me home compared to other people. Anyway, someone obviously has to come pick you up, so went home. I had to do 3 flights of stairs that evening. So to be honest, I did them, and I was probably still all hyped up on analgesia and a bit of drugs and stuff. But did them, went home, and I was like, actually, the muscle still looks pretty normal, and I could activate and everything, so I was quite happy. And then during the first week, that's when it started shrinking. I was like, okay, I'm human too. And the first night was probably not great sleep. The second night was probably not great sleep.
Oh, no, okay.
It was probably about a week worth of not fantastic sleep, just position-wise, and then sometimes...
Can't get comfortable.
No, you can't get comfortable. I hate sleeping on my back. So that's what we had to do. I had to do pretty much.
What about pain? Obviously, at the beginning, sometimes, the first instinct you think, you're going to wake up, but actually, obviously, you've got a lot of pain meds and stuff.
Yeah.
Like, how did it, work? Was it actually pain-wise not too bad, and then it kicks in? Or
I wasn't too bad, to be fair. I wasn't too bad. I didn't take many pain meds. I got codeine, but I used it for 2 days, 2 or 3 days. And then I did take paracetamol and ibuprofen quite consistently for about a week, 10 days. And then I was like, actually, I got a little bit better. And then it got painful again. So I took another cycle of about 5 days of painkillers, but nothing ever strong. It was always paracetamol and ibuprofen. And then there was just random moments of 10 minutes, half an hour of just pain. It was never 10, it was always maybe 6, 7 out of 10, but when that happens at 4 o'clock in the morning, you can't get comfortable, it's really annoying. So it's very random, and everybody's experience is very different. I've had patients that for 10 days they were in absolute agony. Had patients that in day 2 they were like, I stopped any painkillers and I'm fine actually.
A lot of people that I've met post-op, the one issue they have, or the thing that they convey, is that the level of helplessness of something. Sometimes, from upper limb injuries where they can't open things or button their shirt. How was it from your point of view? Getting around and getting up and about. Did it feel like you still could do stuff, or did it feel?
Yeah, I could do stuff with crutches. I mean, it's uncomfortable. It's annoying. You need to think about every single movement that you do. You can't shower properly for probably about 3 days, I found. Just literally getting in the shower, getting out of the shower, it's slippery. It's how do you soap yourself on one leg and everything. Because the first few days, even just standing, then the blood rushes to the knee, and the swelling just feels super heavy and painful. I couldn't stand for longer than 2-3 minutes. It started getting painful. I knew this was going to happen, and again, this is where expectation management was useful, because I knew what to expect, and I was luckily at my girlfriend's place for about 3 weeks, and she knew what to do. She knew that I explained to her what was going to happen, and she knew the fact that I was going to be quite helpless for about at least a week. So she was super helpful. So you do have to have someone around to help you out. Especially if you have stairs in the house, try to avoid being in the house with stairs as much as possible. Try to just avoid doing anything, really. It's the first 72 hours, the first few weeks, really. It's you sit, you do your exercise, you ice, that's it.
And recovery.
That's all you should be doing.
And then you've prescribed like rehab plans and made people follow protocols. Hundreds of thousands of times. How is it on the other side? You're now having to follow something, and with this type of surgery, you have to be very diligent, right?
Yes.
It's not something where a couple of times a week. No, it's every day. How is it on that side?
I knew that was gonna happen, and I bit the bullet, and I had to do it, and I did it. To be honest, there wasn't a question about it. I was super focused in the first 3 weeks. I did my rehab twice a day, ice and compression 4 times a day. Sure, there was 1 or 2 days where I did it only once, and then a little, but for the most part, it was super diligent. It's tiring. It's a full-time job. It's boring. It's tedious. It sometimes can be painful. It's not fun in any way, shape, or form, but it's got to be done. And last weekend I was lazy and I didn't do anything for 2 days. I was in pain Monday, Tuesday.
Damn. Okay.
So you got to do it.
And then as things were getting better, were there any things kind of on the horizon that you were dreading? Any exercise you're like, do you know what? Oh my God! Actually, that's next stage. Damn. Like, do you think can I do it? Or were you kind of, I don't know, geeing yourself up for the next stage?
It was more like excitement of being able to go into the next phase. And this is where the opposite problem comes in, where I've probably been doing a bit much, in the sense that I know the progression of the exercise. So as soon as one exercise felt good, can I do the next step? Can I always do the next step? Where probably for a patient, because they don't know the progression, naturally we tell them stick to this for 2 weeks and then I'll see you. While they might have felt okay to progress after a week and a half, they don't. And that probably saves them a little bit in terms of overload, while I will progress after 10 days because I want to, because I'm a bit impatient and because I know the progression. And while my knee is doing well, there's definitely little pockets of swelling and little things that indicate that I might be doing a little bit too much every now and then.
So a lot of patients, sometimes are on a spectrum where they are either, really taking their time, and that could be because of fear, could be of pain, could be of what people have told them, and then you got the other end, the sprinters that are just absolutely going for it. You say, do this 5 times a day, and then you come back and say, I've done it 25 times a day. Where did you lie? That kind of
I would say in the middle.
In the middle. Okay, so in a good way.
I would say I used my physio brain.
So you followed your advice.
Maybe a little bit, like if it's on a scale of 1 to 10, maybe 6 towards the sprinter side rather than 4 towards the slow side. But I want to say I was pretty balanced with the things I was.
Because they would say clinicians make terrible patients.
Yes.
So how did you?
My terrible patient side was mentally.
Is it?
Yeah. As I started being more about walking and stuff like that, I did a little bit too much.
Yeah.
And week 4, I got sick. I got the flu. And then randomly, I got this flare-up, which I still have a little bit of a niggle on the outside of my knee. After sitting in bed for like 4 days, I got this pain inside the knee, and I got super worried. I got super worried because I know that they've done meniscal sutures, and I know that 1 in 4 meniscal sutures pops. I got worried to the point where I obviously texted the surgeon straight away. Be like, you might have to give me an MRI. And then literally the morning after I texted him, because I waited a couple of days, it's as if nothing ever happened. And it settled, so I felt a little bit ridiculous. And then I remember there was one evening where, yeah, I got super down. Even like teared up a little bit, just because it got to a point where it's been a month of constant pain, and that's the other point, of constant pain, thinking about every single movement, and now I might have to go in surgery again. That was the bad patient side of things for me. In terms of the physical exercise, no, I think I might have been doing a bit too much, but generally doing what I should be doing, and I've been pretty good. I think sometimes a little bit of ignorance is bliss, and it keeps you a bit calmer.
And in your rehab journey, were there any points where you, let's say, had some kind of a revelation, or where you're doing certain movements or certain exercises, you're like, oh, I get why someone might struggle with this, or why that might be painful. Or, for example, you had a feeling where like, oh, now I know what they mean. When they say, oh, this feels like this, now I know. Were there anything like that?
Yeah, I think we go back to that constant pain more from a broader perspective. Living with constant pain and having to think about and feel that pain every movement is mentally super tiring. As I was, you can get demotivated, you can. And then from a more like specific technical perspective, it's weird feeling like you have to load something that hurts. It's counterintuitive, 100%.
Yeah.
And then there was a couple of exercises that I maybe in the past undervalued, and then I tried them on myself and actually thought, oh, actually this is very useful. And vice versa, a couple that I really kind of honed in on in the past. I was like, oh, actually this doesn't give you much value. So that was useful learning opportunity.
And has the experience changed the way you communicate to patients regarding those things like pain, functional limitations, fear? Now going through it, has it?
I think I'm just able to give more examples.
Better
examples, and they can understand that I've been through it as well. So I know what I'm talking about better. I don't think I've changed the technicalities of the communication and the words I use, but I've got more examples to give in that respect.
There's not many occupations out there where having gone through the experience is a prerequisite. You're being a driving instructor who can't drive, for example, or a pilot, he's never flown a plane, for example. But because I've never been in hospital as an inpatient. And I don't think I've had many injuries in the past. But the way we talk about things
that we've not gone through.
But obviously that's part of our training, and I'm guessing what we've listened to all the patients and empathized. But you're obviously in a unique position. But sometimes you do think, you're right. It's giving the examples, but it's not. Now you're all of a sudden a new person. You're still gonna.
No, it's still the same rehab. No, I wouldn't say it's changed everything massively, but so some details, and the little suggestions that I can give. Like, I managed to sleep on my side quite quickly, and I just figured out that actually it was more comfortable sleeping on the operated side if the top leg is in a certain position compared to the other side, where usually we tell people not to sleep on the operated side or the painful side. And then being able to say, look, I know it's boring, I know it's difficult to follow, but it makes all the difference and you just have to do it.
Yeah.
And I'm not saying this because, it's not like the teacher that doesn't have to do the homework. I did the homework.
Yeah.
It's I know.
Are there any things that now you do slightly different with a patient that comes in? Could be with ACL injury or lower limb injury, or if you don't, is there certain things that you were already doing that you're a bit more harder, like that you like emphasizing? You have to do a bit more.
Icing and compression. And the amount of compression. It's not like a little rug tied around. Like, you need to feel like it's squeezing.
Is it? Okay.
And the relief that icing gives. Definitely. So be a lot more consistent with it. while before, I'm not saying that I didn't prescribe it, but the feeling I got being able to feel the benefit of like this is actually imperative.
Yeah.
And the other thing is consistent muscle activation.
Yeah.
Which I knew, which I, from my own kind of bias as a therapist, has always been strength. So always really honed in on it. But again, having felt how much better the knee feels when you stand up after you've done your exercise.
Yeah.
It's being able to explain those sensations better. The knee, instead of feeling muffled and tight and very mechanical, robotic in feeling, it's smooth.
Yeah.
And then they really understand, like, oh yeah, that's exactly how I feel, and then they really do then do it.
Do your patients know what you've been through?
Yes, I did tell everybody.
Yeah,
Absolutely, I did, and everybody's been lovely. To be fair, everybody's been asking like how it's going. They do find it quite funny that we're both hobbling around the gym instead of only one.
Does it help with not credibility, but if a patient does say
it's credibility. It is credibility, honestly.
When they're saying, "Oh, you don't understand," you're like, "What?"
It is credibility, and but when you talk to anybody about anything, and they tell you, "Oh, I've been through it," you feel a connection instantly, and it does help. 100%.
What about again, taking it back to the protocol and stuff, maybe more like milestones. We've got that different phases.
Yeah.
Going through it again, we do know that these kind of milestones are rough. And everyone's different, and the injury itself, the mechanism, what they've actually fixed, can really change things like that. But going through it yourself, first of all, were you looking at those timelines, like, oh, I'm at 6 weeks now? Were you focused on that a lot?
Yeah. Not a lot. But I want to say I'm a little bit ahead of the curve at the moment.
Okay, good.
But I've got this lateral pain which might stop me at some point and drag me back a little bit. And that's another thing that I've found actually quite difficult, not comparing the patients I see to myself.
Yeah, because that's what I was going to say,
that's tough.
Yeah.
Because whatever good or bad I've done, felt, or experienced, that's my body and my knee. They might feel something completely different, in pain, and they might do something better than I have done. So I can't then give them a little bit more anxiety, which they don't need. Nobody needs extra anxiety after something like this.
Would you say, with the patients, is there, obviously they know now you've been through surgery itself, and those that are comfortable, is there any pieces of advice or kind of with your experience, maybe those that have a lot earlier in their kind of rehab, so let's say a few weeks post-op, something, is there anything, the kind of words of wisdom that you do try to give them? That's not very clinical, not about icy compression, maybe more kind of supportive words,
I think it's just the sharing the experience that is a little depressing, it's a little boring, it's long, and to just to keep on going, because it will get better, and it always does. I think it's more sharing that feeling, sharing the experience. That, as we said earlier, it helps a bit of credibility, and I certainly always feel that if someone tells me, "Oh, look, I've gone through it, it's gotten better," that calms me down. I have a patient that's emailed me a couple times, being like, "Oh, I got this pain. Is it okay?" Or "I slipped the other day. It feels completely fine. Should I look out for anything else?" I was able to say, "Look, I had a flare-up last week. That lasted 3 days, and it was completely fine. I had a slip two weeks in, and it was completely fine. The symptoms were the same. You're good." From a patient hat, and then from a clinician's hat, obviously analyzing the actual situation.
And for all the practitioners watching, is there any kind of advice about patient-centered care that you think,
especially people like me who've
Yeah.
not been on the other side, is there anything that we should do or think about more that you think now, obviously, you're that one step ahead in because of your experience?
Give them reassurance and time and guide them through the movements, because it is a bit scary to do things. And the most important thing is don't rush them once you've cleared the red flags, of course. So the things that are actually urgently in need of a review, or A&E in the worst case scenario. Time doesn't matter. If you run a 3 months or 4 months, or it doesn't matter, it's criteria. It's always criteria, and you need to pass them. And there is very little leeway. There's some leeway on some criteria, but very little. And you should be strict with it. And you should guide the patient literally, like, by the hand. Give them lots of education, make them understand what's going on, and then they'll get less fearful. If you understand the theory behind it, it's less unknown, so less scary.
Is it something that because you were surrounded by physios and obviously you did a lot of rehab yourself, so you went, you didn't go through the experience of being rehabbed by strangers essentially.
Yeah.
But is there certain things that, we shouldn't say to someone?
Any scaremongering with regards to movement or future plans. You're not going to be able to ski anymore. You're not going to be able to play football anymore. You're going to get arthritis. No, there's no evidence that says that we can predict any of it.
Yeah.
You might be more at risk, sure. And am I more at risk for a third injury? Yeah, sure. But I don't know. Either you live in a bubble, or you go out and with being sensible and carry on with your rehab and everything that you need. Go do whatever you want because you can, because there's at the moment a 40-year-old skier winning World Cup races with a partial knee replacement, because Andy Murray finished Grand Slams with the hip resurfacing, because there's obviously, look, they're at the highest level of strength and but structurally they did. So it's we can do a lot. Push the patients to follow the rehab properly and not sprint, but push them to do everything that they want to do.
Yeah. You've learned a lot from this, I feel, and it's great to see where you're at now. And it's funny, when people do have experiences like this, I normally would then say, do you recommend everyone to go through it? But obviously I'm guessing it's not good to recommend.
No, God, no. If I could have avoided all of this, I would have avoided it.
But I think
if I could have not taken that last ball, I would have not.
But you recommend the take-home points, which I'm guessing we can learn from speaking to either obviously colleagues that will have a different perspective. But I'm guessing what you're saying is listening to the patients themselves as well, isn't it? A bit more kind of like their internal experiences.
Because they might interpret a certain pain or a certain sensation in a certain way, and then you're gonna have to educate them to what it is, to then allow them to be more confident, and that different people are in different ways, right? So certain people need to be told, certain people need to be shown. Certain people need diagrams and need to know the anatomy and need to know the numbers and the percentages. A lot of the more analytical type people, while some people are a bit more, they just need reassurance.
Yeah. And finally, how far into your rehab are you? And how's it going? And what's the future, the near future hold?
So 6.5 weeks in now.
Wow, yeah.
I've been walking with no crutches for 2 weeks. So I did the whole of last week of work and the whole this week with no crutches. With as I said, this little bit of a niggle. I'm doing cycling. I'm doing basic kind of exercise. You sit to stands and a little bit of weight already. Your leg press and leg extensions. do your leg extensions. And then the next steps will be hopefully running between 3 and 4 months. That's the usual, obviously criteria based as usual, but we're looking to get there between 3 and 4 months. Over Christmas, I'm looking not to walk. Try to just sit on the couch, do my rehab and ice, and not walk, and give the knee a bit of a rest.
Fueling yourself?
Fueling, yeah. Well, I'm going to Italy, so yeah, possibly over fueling.
Yeah.
Carbs more than protein usually, but hey. And I'm looking to start adding some weights to my like squats and those type of movements. Hopefully soon. It's not quite time yet. I can't quite bend comfortably. And then yeah, a little bit of swelling and this little pain. Trying to be a bit more conservative because I got told off 2 days ago by Mike. I was doing a bit too much.
But that's testament to your improvement. That I didn't even know it was that. It's only 6.5 weeks. I thought it was
weeks.
a bit longer. The way you're moving really well.
Yeah, no. To be honest, like I'm happy with how it's going. I am happy. If I didn't get sick of 4 weeks, I would have even been able to do a little more. But since I'm already doing too much, maybe the flu was a good thing.
That's amazing, Dani. Thank you so much for sharing your experience. It was really insightful, and I hope a lot of people have taken some of those tips and messages from you. And we look forward to seeing the rest of your journey, and maybe we'll get you back in 6 to 9 months when hopefully you're doing tons and tons more.
Yeah, I'm kicking a ball already.
Thank you very much.
Thank you very much. Appreciate it. Thank you for having me.